Hello, my name is Dr. Yelena Janjigian. I'm the Chief of GI Oncology Service at Memorial Sloan Kettering Cancer Center, and I'm excited to talk about some important cases in gastric esophageal cancer and how we manage this disease in the clinic. These are my disclosures. So the learning objectives for today is to recognize patient characteristics and key actionable biomarkers in gastroesophageal cancer, how we can optimize treatment strategies by implementing evidence-based sequencing techniques and considering efficacy and safety profiles of available therapies, incorporate complementary interventions and professional setting for the disease management teams. So the first case is a microsatellite unstable tumor. This is a patient who presented to see me with progressing disease. She initially presented in her local hospital with T3N1 tumor, HER2 negative gastroesophageal cancer. At the time, imaging was negative for metastasis and patient was treated with carboplatin paclitaxel radiation. This was the so-called cross regimen many years ago. But she developed malignant supraclavicular and retroperitoneal lymphadenopathy while on that treatment. At the time, the doctor biopsied her metastasis and showed biopsy-proven metastatic adenocarcinoma, and the patient went on to receive additional cycles of FOLFOX now for metastatic disease. She was referred to us. She was on FOLFOX, appeared to be progressing, and sequencing of the tumor at the time showed that she had microsatellite instability with 31 mutations detected on NGS, including MLH1 splice variant. So this patient received chemo initially with progression of disease, and then subsequently we treated her with nivolumab on Checkmate 32 study. This is many years ago, and then she subsequently developed a complete pathologic response, and to the point where she had perforated her tumor and required surgery. So this led to real amazing result. Case 2 is a patient with HER2 positive disease. This is a 45-year-old man with metastatic HER2 positive tumor, IHC3+, gastroesophageal adenocarcinoma involving both lungs. He started on a clinical trial with capecitabine, oxaliplatin, trastuzumab, and pembrolizumab. This was on a phase 2 study before our phase 3 study and FDA approval of this regimen based on Keynote 811. And as you can see here, even just with one cycle of tras-pembro pretreatment, we see here this robust benefit of the tras-pembro with one cycle, and this robust benefit of 2-year treatment. On treatment, he had a complete resolution of, and this was a durable benefit he went on to see with this regimen. Case study 3, we have a 53-year-old woman with a stage 4 gastric adenocarcinoma. She presented with bloating and early satiety, 25-pound weight loss. This is a very typical presentation of the disease with peritoneal carcinomatosis, and she had endoscopy and biopsy showed ulceration. With biopsy showed invasive adenocarcinoma. On the CT scan, she had a 2.5 centimeter lesion and lesser curvature with peritoneal carcinomatosis. Pathology confirmed moderately to poorly differentiated adenocarcinoma. This is a good example of what routine biomarkers we do in the clinic, including HER2 with IHC0 using the Ventana assay, PD-L1 overexpression by IHC, combined positivity score of CPS 20. And this is using a E1L3N clone. So as long as it's CLIA approved, our lab can use pretty much any CLIA approved clone that's equivalent to 22C3. And MMR proficient tumor, both, so all four MLH1, MSH2, PMS2, and MSH6 are retained. What's interesting is this tumor has KRAS G13D alteration, PI3 kinase mutation, but otherwise no targetable alterations. So before advent of immunotherapy, this patient would not be able to really get anything other than standard chemotherapy, and the median OS in that setting with standard chemo is less than a year. This patient went on to receive therapy in one of our earlier trials with Checkmate 649 and had a complete clinical response. She received up to 12 cycles of FOLFOX nivolumab. We discontinued oxaliplatin after actually cycle 11 because of neuropathy, and then she was maintained on 5-FU nivolumab for up to 2 years. And again, because of this unique tumor biology, had a complete response, so now is doing well on capecitabine maintenance years after the initial complete response. Her repeated endoscopies showed no active tumor, benign. Biopsies and CT scans showed resolution of radiographic disease. So this question, I think, just to go back, answers a few of these points that come up quite frequently. What do we do with these patients with complete response? Do we stop treatment? Do we stop or continue some sort of maintenance therapy? Typically after 2 years of immune checkpoint blockade, at least in patients with microsatellite and stable tumors, the data supports stopping therapy. For this patient, certainly on a clinical trial, it was appropriate to stop all treatment with immunotherapy. But most patients are quite hesitant to stop everything. In fact, we have patients in our clinic who continue on treatment for years. And so, whether or not to stop at 2 years or continue is really a good question. But most stage 4 patients continue on some sort of maintenance capecitabine therapy. So lastly, this is a patient with perioperative, in the perioperative settings, a 70-year-old construction worker who presented with 2 weeks of difficulty swallowing. Endoscopy showed friable mass at 43 centimeters, and biopsy confirmed adenocarcinoma, moderately to poorly differentiated. So standard biomarkers, as we reviewed earlier, include MMR, which was proficient. So this is non-MSI tumors, HER2 negative, and PD-L1 positive tumor, CPS5 or greater. PET showed an FDG-avid tumor, CV14. On PET scan, so we typically get a CT scan and a PET scan to rule out metastatic disease. The PET scans sometimes can help identify retroperitoneal, supraclavicular, and bony metastasis in up to 10 to 20% of patients. In this patient, there was no active metastasis, and on a laparoscopy, this was a T4 tumor. We also like to do staging laparoscopy for gastroesophageal cardia tumors, which is what this patient had, and there was no peritoneal involvement, although this was a pretty advanced tumor going through the muscularis propria into the serosive T4 tumor. So these patients have very high risk for systemic disease recurrence. And even though he's a 70-year-old, he's a very fit construction worker, so he would be a good candidate for triplet regimen. We start with FLAT. So FLAT is 5-FU, leucovorin, oxaliplatin, and docetaxel. And we often require dose reductions or even start with lower doses in patients who have difficulty. But in this patient, he was a good FLAT candidate. I like to use growth factor prophylaxis with first cycle preemptively, as the grade 3-4 toxicity, including febrile neutropenia, can be associated with this regimen. And so this patient went on to actually consent for the Matterhorn study, had FLAT durvalumab or placebo with good response, followed by surgery. So in the Matterhorn study, we demonstrated that perioperative FLAT, durva, or placebo were feasible in 100% of patients, nearly completed all components of the regimen. 91% of patients had complete surgery, R0 resection, equivalent in both arms. So the impact of addition of durvalumab had no negative impact on likelihood of surgery. And then patients went on to receive FLAT, durvalumab, or placebo in adjuvant setting with up to a year of adjuvant therapy. So in this patient, he had a nice response on the PET scan, which actually translated to complete pathologic response. The question comes up in patients with complete pathologic response is what to do in adjuvant setting. Should we continue adjuvant chemotherapy in the patients? What we see is in Matterhorn study is improvement in disease-free survival, even in patients with R0 resection. So it highlights the importance in micrometastatic disease control. And biologically, I think about it separate. The primary tumor and micrometastasis are separate compartments of tumor burden. And even if you have a complete response and a major impact on primary tumor, the impact on micrometastasis is still important. And so in my patients, I tend to favor clinical decision of whether or not additional chemotherapy and immunotherapy is feasible. So if the patient has, plateaued on their weight loss, so they're no longer losing weight, if they're able to eat and do their daily activities, they're functional, they're came into your clinic, they reached a new steady state, and they are able to nutritionally support themselves post-surgery, those typically are a good time to resume. Usually it's flexible. Adjuvant therapy can be resumed up to 3 months after surgery. And again, the timing of it will depend more on clinical features rather than the pathologic complete response. I favor to continue therapy even in patients with complete response, even if it's dose escalated, de-escalated, such as stopping docetaxel or oxaliplatin and continuing with 5-FU, for example, immunotherapy. So I hope you enjoyed these cases. The key takeaways from our really discussion today is that you really have to make sure you test your biomarkers and you know your biomarker results. And we talked about microsatellite instability, HER2, PD-L1, Claudin, and now going to be FGFR2b. Biomarker testing in perioperative setting is important, as well as first-line setting. Perioperatively, particularly identifying MSI tumors, HER2 positive tumors, and metastatic tumors, is important for use of immune checkpoint blockade and anti-HER2 therapy together. Usually it's flexible. Adjuvant therapy can be resumed up to 3 months after surgery. And again, the timing of it will depend more on clinical features rather than the pathologic complete response. I favor to continue therapy even in patients with complete response. Thank you for joining us.